Langsung sambung kamera laptop ya.
Iya, kemarin saya coba ngerekam
Apa
pakai
Bluetooth?
ini tapi lebih 32 giga. Saya coba semalam download selesai kita
Bisa.
punya. Iya. Saya coba cara baru ini. Kita langsung kontak ke laptop.
Bluetooth sih atau apa?
Dia connecting antara Apple.
Oh, Apple TV.
Iya.
Oh iya, langsung bisa.
I'm so sorry because you cover up a lot of places, so that's why I don't know whether I can get you the best thing or not. Um, your time yesterday, where did you go? It's nice. Love that, right? Love that one. And how long did you be there? Around 4 hours. So today night also my student they will take it all around the village. Again, let's start our work today. I would like to introduce Professor Lilia from Faculty of Psychology, Madani University. She will give a lesson for all of you today. And from Faculty of Psychology, University, I also would like to introduce Dr. Nam. Yes, from Mahidol University. He graduated from Mahidol University. Now he has been working in the University, right? So because also here is Mahidol University here, so can you introduce yourself a little bit?
Good morning, all. My name is Nam, and my major is social economic and educations pharmacy. So almost my research on the economic, and on the Mahidol University in Almarisah. It's one of my advances. Almarisah akan mau grad. I have 6 years in Mahidol in Thailand already, and also 2 years master in Chulalongkorn University, and 4 years in Mahidol University in the PhD. So I also have take the responsibility as the exchange course in the Mahidol University when the student come to the class, and for the 4 years I have stayed there. I have the response and pick up all of the students come to class to exchange in there, and now very welcome to Almarisah University for the first time that you stay here. Thank you very much.
Okay, now your time, thanks.
Thank you. So good morning, everyone. I believe you have your wonderful breakfast today. Yeah, so you can absorb all the things that I give you today. Yeah. So yeah, it's wonderful to see so many familiar faces here and also new faces. But I think some of my students are nervous today because they asked me whether I'm going to give exam or not today. Okay, the answer is, let's see. Okay, so I would like to introduce myself a little bit. So I'm Professor Yulia, and I come from Stanford University, Faculty of Pharmacy. So I graduated in UNHAS in 2001, and then I pursue my Master of Biomedical Science in James Cook University. I come back and then finish my master degree again in pharmacy in Hassan University, and then come back to Australia again to do my PhD in physiology and pharmacology in James Cook University, Australia. So I've been working with UNHAS since 2002 till now, and now they give me a job as a Vice Dean of Partnership and Research and also Innovation. So for today, I would like to tell you about the pharmacology of congestive heart failure treatments. Yesterday, Dr. Ayat already gave people a lot of information about how the heart can function normally. And so maybe I don't need to go through that again, but I would like to, I don't know, a little bit of recap probably, just to refresh your mind, because we're going to discuss about what happened with failure. Probably I would like to know if you still remember what happened if the heart is still normal. Let's channel our inner heart and then ask yourself, if you are a heart, what would you need to function normally? Anybody? Electricity? Yeah. Electricity, you mean the electric function of the heart? That's correct. Because you need electricity of the heart to make it work, right? From sinoatrial node, right? That's one. Anybody? The blood, of course, you need the blood to fill into your heart in order to pump out, right? You pump out from the heart to all over your body. Anything else? Muscle, what do you mean by muscle? Is it skeletal muscle or just heart muscle? Just the heart muscle? Just the heart muscle, yeah. We're talking about muscle, but in the heart. So we call it cardiomyocyte. Well, that's the detail, yeah, just heart muscle. Okay, because yeah, without heart muscle, we cannot pump the blood. Because we need muscle to do that, not the sinoatrial pacemaker, because yeah, we call it like node, yeah, the one that give electricity to the heart. Anything else that you can remember? Give the pressure to the blood, contraction, you mean, yeah. Of course, do you know that the left side and the right side of the heart have different function? Yeah. Yeah. So let's talk about what is more important to pump your blood all over your body. Which one? Left or right side? Left. I heard that something. Left? Yeah. Smart. Yeah, it's left. Okay, so now we're talking about the left side of the heart because we're going to talk about heart failure, which actually the failure of the heart to pump the blood out of the heart and goes into your aorta, right? So that's the ventricle function, the left ventricle function. So everybody agree with me till this point? Yeah. Okay. So let's start with this. So what's the objective of my lesson today? The first one, review the pathophysiology of the heart failure. Because you already learned about the physiology, now I'm talking about the pathophysiology, how when it fails to function. And then the second one is to distinguish the stages of heart failure, because not all failure is painful. Yeah, there are some stages, but when you come with the fourth stages or the severe stages, then you might need medical attention immediately. Okay? And then I would like to also outline the classes of drugs that we need to treat heart failure. And last but not least is to understand the mechanism of actions of the heart failure treatments. Okay, let's go to the heart failure. So actually, if we use a very simple term for heart failure, it's a complex clinical syndrome in which the heart cannot pump enough the blood to your body, because that's the main job of the heart, because they need to pump your blood throughout your body so your body can get blood which rich in oxygen and also nutrition. So actually there are two types of heart failure. The first one is diastolic heart failure, where your heart cannot relax, cannot diastole, cannot stretch in order to let the blood fill into your ventricle. Yeah. So if the heart cannot relax and the heart cannot be filled enough with the blood, then you cannot pump enough blood. Does that make sense? Yeah. And the second type of heart failure is when your heart is dilated too much, it cannot contract properly. So it just dilates, and then because it has to wait there's one there. Okay, this one. Okay, oh, wait. For diastolic heart failure, they have big ventricle, so much muscles here that the space in the ventricle is lessened compared to the normal heart, and that's why you cannot feel the blood enough to get out of the heart, yeah, the enough blood. But in systolic heart failure, you have so thin ventricle walls that it cannot contract properly. Yeah, even though it's filled with blood, but it cannot contract properly. All right. So let's see what happens with the normal heart and with the heart failure heart. Okay, this is what happened in the normal heart, where the ventricle can pump the blood that get into your ventricle. So in here, the movement. And then for the heart failure part, look, you can still have some blood in the ventricle space, and that means that the heart can pump the blood out sufficiently. Okay? Right. So let's see how many people dies out of heart failure every day. Let's just focus on Indonesia and Vietnam. This is like 200,000, 200 people around, yeah, around 200 and 300 people. I'm sorry. Per 100,000 population. So it's quite high, but not as high as Western, yeah, Western Asia. You can see it's very so many people die compared to Indonesia and Vietnam, but it's still high. We don't want that. Okay, so what is the symptoms of heart failure? So actually, it's not. Maybe people say like this: if you have heart failure, and then probably you always feel pain in your chest. That's not the case. Okay, so mostly patient will come to the hospital because of short of breath. Okay, dyspnea. They cannot breathe properly. Yeah, and the second symptoms will be they will feel so weak, fatigue, because the cells, including their muscle cells, the skeletal muscle cells, cannot get oxygen. That's why they cannot, they don't have energy. They cannot move, well, they feel very weak. Yeah. And then palpitation. Palpitation means that your heart beating so fast, but it doesn't help with the cardiac output. Even though it's beating fast, but because it doesn't have enough muscle cells to contract, then they just do like this. So it's not as strong as normal heart. That's why even though they beat fast, they cannot, pump the blood out. So that's actually one of the compensation that our body gives to the heart, saying, okay, we have less blood, let's make it faster. But that's not helpful at all in this case, when people already have heart failure. Okay? And you may also see patients come with edema or the swelling of the ankle. You can see they have that, swelling ankle. And that's because they have so many fluid retention in their body because the heart cannot, the blood who's trying to go back to the heart cannot do that properly because the heart itself was already full. Okay? So in order to refill the chamber of the heart, of course we need to empty it first. Right? Okay, and that's not happen in heart failure patients. And then you will also, patient also gonna have increased weight because they have so many fluid retention in their body, right? So they have edema everywhere. Of course, you can have edema. Okay, all right. So why heart failure happens with the patients? Mostly because they have coronary artery diseases. Due to atherosclerosis, probably. Yeah. So the heart cannot get enough blood that they need. Because when the coronary artery is blocked, of course, your heart needs also blood, not just other cells, but your heart cells also need blood. And who feeds them? Coronary artery, right? So if it's so small, so if you have like plaque, like lipid plaque or polyarterial sclerosis, then the blood cannot get through to give the oxygen and nutrition to the heart cell. And that's why they weaken, that's why they almost die. Okay, so mostly people with heart failure, firstly, because of they have the coronary artery disease. Okay, and then the other one is also high cases because they have hypertension. Yesterday we already said that hypertension is not to us, but do you know one of the risk factor of heart failure is because you have hypertension. Why? Like I said before that the heart needs to pump the blood, right? Through the aorta. You got me there? Yeah. And aorta is like the mother of all of your artery, yeah, in your body. That's the mainstream, yeah. So it means that the pressure that you have in your arteries will also influence the pressure in the aorta. Okay, and the pressure in the aorta will determine whether the heart can pump to the aorta or not. Let me analogize like this. If the room is the ventricle, if this room is a ventricle and it's filled with blood, and then we have door over there, and that door in part we call it valve, right? And let's think that outside is the aorta. Okay, so what do you need to pump the blood from this room to aorta outside? What do you need? We have the, what do you need? Open the door. How to open the valve? How to open the door? We need to push it. We need to push it. So if we need to push it, do we need less pressure here or less pressure there?
Less pressure here.
Here.
Let's pressure them because we want to push it. Of course, we need more pressure here, right? To open the door over there, to go that way, to pump the blood outside. So it means that we need the pressure in the ventricle more than the pressure outside. Like I said, the pressure of aorta, it depends on what? The pressure of your artery throughout your body. Okay? Yeah. So it means that if you have hypertension, then the aortic pressure is higher or lower?
Higher.
Higher, of course. Right? In that case, hypertension is good for us or bad for us? Bad, because we need more pressure here to overcome pressure outside, to be able to push the door, right? So that happens, when that happens, it means the heart needs more pressure or more workload. We call it workload. Yeah, means that the heart needs to pump very strong in order to overcome the pressure outside if we have hypertension. And that makes the heart, because the heart have to keep working and working and working. Do we need less energy or more energy? More energy. More energy. So how do we get energy? We need more blood, we need more nutrition, we need more oxygen. Can we to make ATP? ATP is the energy of the cell, right?
Yeah.
Okay, you're with me. So in order to get ATP, we need to make ATP, right? Yeah. So can we have ATP depletion? It means can we finish our ATP? Yeah, we can. If we don't have the source of enough oxygen, not having the source of enough nutrition, right? So the ATP that we produce can diminish if we keep using it rather than saving it. Okay, so one of why people who have hypertension easily get heart failure because they need to produce more energy and because there are more demands. You ready?
Yeah.
Yeah? Okay. So it means that people with hypertension can easily get diminished ATP, and that's why they get diminished, what do you call that? It means that their cell may be starved. You with me? Yeah, and then when they starve, they can die. If you starve, you can die, right? You can function very well. And that's what happens to the heart with hypertension. So please try to control your blood pressure, yeah? Okay, that's high blood pressure. Let's do the cardiomyopathy. So some people can also have abnormal function of the heart muscles because, well, maybe there's infection, maybe there's viral, there's other diseases that can make the cardio function abnormal. Yeah, that's what's called cardiomyopathy. Okay, and that also can influence and determine the performance of the heart muscle. And then the last but not least is the faulty heart valves, which means that the door of the heart, the function is abnormal. It's not function properly. Okay. All right. So now we move on to the heart failure classification. So actually, I don't know if you are familiar with American Heart Association, right? Yeah, of course. You're also familiar with NYHA, right? New York Heart Association. Okay. So actually, for heart failure stages, they use like these two terms. Okay, use the American Heart Association using A, B, C, D, and the NYHA or New York Heart Association using 1, 2, 3, 4. Okay, they have different classifications. So for the heart association, I mean the American Heart Association, they would use the abnormality of the structure of the heart to classify whether they stage A, stage B, stage C, or stage D. So when they're stage A, they still have no abnormality of their heart structure. Okay, but B, they maybe don't have the abnormality of the structure, but they already have symptoms, right? The symptoms is like shortness of the breath, yeah, they cannot breathe properly. And then for the C, they already have the symptoms and they already diagnosed because the abnormality of the structure of the heart. And then the D, well, this is the one that advanced heart failure, where the structure itself is already changed and also the symptoms persist. Okay, so they have to be hospitalized many times. Yeah. Then for the NICA, what they look at is whether they have physical activity and they exhausted already. For example, when they still can have normal activity, a little bit light exercise, and they still can function, it means they're still in stage 1, no limitation. But when they run, they're panting, yeah? It means they're in NICA stage 2, right? And then for NICA stage 3, even though they're walking, they already feel like shortness of breath. And for 4, they can be, even though they're sitting or laying down, they already cannot breathe properly, right? And then we also have a classification based on their ejection fraction. Oh, this is a difficult term, right? Anybody still remember what is ejection fraction? Just checking from Dr. Ayari lesson yesterday. I hope no. Okay.
Already.
Let me well, this very short, yeah. So ejection fraction is how much blood you pump out from the ventricle compared to how much blood being filled in the ventricle. Yeah, that's the ejection fraction. So yesterday, Dr. Ayani says that it's about 60 to 70%. That's the normal one, right? But for people that in heart failure, well, sometimes they have preserved ejection fraction. It means that it's still around that 60%. That's still not severe, right? But we are worried when the patient is already have reduced ejection fraction. Yeah, because the blood is not coming up, even though they're trying to pump. It's only less than 1%. And usually for a patient like that, we need medical attention immediately. We need to go to ER or ICU. Yeah, something like that. So maybe that ICU, emergency, yeah, unit. Okay, okay, so if we want to treat patients with heart failure, may I know in here in this classroom, do you already learn about heart failure in your university? Yes. 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 Okay, that's like what, fourth year or third year? Third semester. Third semester. Oh, that's great. Yeah. I hope you stay. You're now in what year?
In my second year.
Oh, okay.
I'll actually at third semester.
Oh,
Learning this.
okay, so you already learned this. Oh, great. Okay. So usually pathophysiology of the heart failure, it means like how come heart failure is developed in a patient. Yeah. So actually, like I said yesterday, the main reason is because we don't have enough blood to be pumped, yeah, by the left ventricle throughout our body. But our body needs to fix that immediately, right? Because we have like compensatory reflex reaction. Compensatory reaction, is that how you would call it? Yeah. Oh, sorry, compensatory mechanism. Right. Okay. So the body will try to activate the neurohormone, which means that okay, the brain can sense, oh, we have less blood than what we need. We have insufficient blood. So let's activate everything, including our neuron, including our hormone, to be able to increase our blood pressure, not blood pressure, the volume of the blood, right? So what do? They will activate renin-angiotensin-aldosterone here. Right? Are you familiar with this one? RAA system? Because RAA system will help you to increase the blood volume, right? Because the body thinks that's the only way to make our blood sufficient again. Okay? And the next thing that they activate is antidiuretic hormone. Right? They release that antidiuretic hormone to preserve whatever food that we still have. It means they're gonna make our body not to what do you call it? Not to throw up more liquid, right? Because they're gonna retain that liquid in our body. And then the next thing they will do is to activate the sympathetic nerve activation. It means they will try to make the heart beat faster. Because in our mind, when we have less blood, then we need to make the heart to pump blood faster. That's what they thought. Okay. And then in order to do that, they will release more norepinephrine and epinephrine, which are the hormone for the sympathetic nerve activation. And last but not least, the ventricular remodeling. This means that because your body thinks that, okay, we have less blood. Maybe if we produce more heart muscle, make it thicken the ventricular wall, probably in that way, we can contract more powerful, right? But what we see, when ventricle get thickened wall, the space is less. Did you see it before? Yeah, the space for the ventricle is less than the normal, normal heart, right? Because it's thickened, the wall is thickened. So that's why they do ventricular remodeling. So what they aiming is not is what do you call it? Is missed. I mean, they thought when they are making it thicker, then they will help the heart to contract forcefully, but that's not the case, right? And another thing is that, so ventricular remodeling can be either hypertrophy, which means thickening of the ventricular wall, or probably dilatation. Yeah, because the heart also think, okay, maybe we don't need so much ventricular wall, maybe we're gonna make more space for revealing the heart. And that's why they do the ventricular remodeling for dilatation. But again, it depends on the cost, okay? Depends on the cost. What the what do you call it? What condition of the patients, okay? So this is just like scheme, yeah, simplify, just to make you know when your cardiac output is decreasing, then your carotid sinus also decreasing. You know the sensor yesterday that Dr. Ayani was talking about, and then when that decreasing, then our body will increase the sympathetic discharge because they think we need faster heart, we need forcefully contraction. And that causes increased force of the heart, increased heart rate, and increased preload. Preload is the stretching of the heart, yeah? And in order to make cardiac output increases, yeah, but this is only compensation. It means that it only happens temporarily, yeah, not permanent, yeah? Yeah, I mean, they're trying, yeah? But then, the heart gets tired, yeah? And then because they have ATP diminished, and then they're gonna have heart failure. Another way is that when the cardiac output decreasing, and then the renal blood flow also decreasing. In the renal, we have what is it? A sensor. When the oxygenated blood in the renal decreases, then the renin will be released. Then when the renin release, of course, we're gonna be having increasing angiotensin 2, right? You're familiar with angiotensin 2, right? And then when angiotensin 2 increasing, of course, you're gonna increase afterload. Afterload is the pressure of the aorta, yeah? So the pressure of behind that one, okay? So it will increase afterload, and then it will induces remodeling, yeah? Okay. So if you know all of this, then you will know the treatment of heart failure. Yeah, because all of these things, this increased force, increased rate, increased preload, increased afterload, and remodeling are the main cause why patients got heart failure. So if you want to treat heart failure, what would you do? What would you do? You will try to decrease the force. You with me? Yeah. You will try to decrease the heart rate. Yeah. In order to save energy of your heart, your ATP, you will try to reduce preload. You will try to reduce afterload, which is the pressure of the aorta, which is determined by your arterial blood pressure. And then you will try to reduce remodeling to save patients. Okay. So Now we are on case study. So this is your patient. He is 65 years old man. He has developed shortness of breath with exertion several weeks after experiencing a viral illness. It means that he got infection, viral infection. And then we can see the patients have swelling of the feet and ankles and increasing fatigue. On physical examination, he is found to be mildly short of breath laying down. So even though they're laying down, and he is laying down, he will still have short of breath, yeah? But feels better sitting upright. The pulse is, well, still normally a little bit high, 105. And he has regular and blood pressure is 90/60 mmHg. An echocardiogram shows that he has a dilated, poorly contracting heart with a left ventricular ejection fraction about 20%. So it's way down, yeah, because the normal one is 60 to 70%. And the presumptive diagnosis is dilated cardiomyopathy secondary to viral infection. It's stage C. It means that it's already symptomatic. It has symptoms, right? And it also has heart failure. It means that if he has shortness of breath, even though he's just sitting down. Okay, so if you are the pharmacist and with the doctor to take care of this patient, what would you do? Okay, let's talk about it later. So these are the options, yeah. Treatments of congestive heart failure. Okay, so these are the options that we have. We have RIA system antagonists, we have beta blockers, we have diuretics, we have aldosterone antagonists, we have SGLT2 inhibitor, and also cardioglycoside. Are you familiar with all of these drugs? Yes. Great. Okay. So again, I don't need to explain. Very long, yeah. Only short one. Okay. So when we're talking about RNA antagonists, then we're talking about these four classification, yeah, including angiotensin converting ACE inhibitors, which is usually we just shorten it to ACE inhibitor, right? And also angiotensin receptor blockers, which is ARB, aldosterone antagonist, which is mineralocorticoid receptor antagonist. They can be switched, right? And then angiotensin receptor neprilysin inhibitor. This is new, very new. Have you heard about that? There is neprilysin inhibitor. Yeah, so in Thailand, it's already used in hospital or in clinics. That's good because not us yet. Yeah, in Indonesia, not yet, but it is new drug. So probably our students have not heard about this neprilysin. Have you? No? Okay. All right. So good. At least you got something new today. Okay, so the only neprilysin inhibitor that is in market now is sacubitril, yeah. The one that already been proven by FDA, sacubitril. It's already in one what do you call it? It's dual drugs, yeah, in one tablet, one tablet with sacubitril. This is angiotensin receptor blocker. That's the only one that's already get proven by FDA. Okay, I don't think I need to explain this, right? Everybody already know about this. There is a system. Yeah, so we're just gonna focus on the angiotensin converting enzyme here that have a job to convert angiotensin 1 to angiotensin 2, because the angiotensin 2 has so many effects that can raise our blood pressure. So we don't want angiotensin 1, angiotensin 2. That's why we inhibit ACE, right? And then we can also just inhibit the receptor by ARB. Yeah, and I think you all know this, all right? Right? Maybe I don't need to go through that too long. Okay. So again, same thing here, yeah, so I would like to mention that we can also have antagonist of aldosterone. In this case, it's spironolactone or planarine, yeah. Because we want to make sure that the volume of the blood is not increasing, because that's the one that makes increased preload. We don't want to increase preload. Okay, so yeah, this is the new one, nebulizing. Why is it important? Why is it the new target of heart failure drug? Because nebulizing is actually an enzyme that can inactivate the here. Sorry, this BNP. BNP is B-type natriuretic peptide, which we release from our ventricle when the ventricle stretch. Yeah. So when your ventricle stretch too much, they will release BNP. And BNP is like an indicator that your heart is already stretched, right? So, but besides that, it also have function. Yeah, it can have vasodilation function. It can also have adrenal function because it can decrease aldosterone production. And in kidney, it can increase natriuresis and diuresis. It means that if you have increased BNP, it means you're gonna pee a lot. Okay, that's how we understand that, right? So this is good for people with heart failure because when we have increased BNP, it means we can decrease our blood pressure by producing more urine. Okay, you with me? Yeah. So because we don't want this to be inactivated, then we need to have the inhibitor of the enzyme, nebulizer. So we use this inhibitor to make nebulizer not degrading BNP. Okay, in that case, we're going to have less blood volume and then good for heart failure. Okay, so I'm just saying that this is all the ACE inhibitor. I don't know, Dr. Aswad tomorrow probably will talk about different types of ACE inhibitor and how the structure will determine how it affects our body. So it's good. So I don't need to explain this because Mr. Aswad, Dr. Aswad, sorry, will do tomorrow. Okay. So again, yesterday Agung asked what are the side effects of the hypertensive agents. So for ACE inhibitor, you can see, of course, no drugs have no side effects. They all have side effects, right? But we have to choose which one has less adverse effect to our patients, yeah, and more therapeutic effect than the adverse effect. So for ACE inhibitor, you can see that we can make the patient have severe hypertension, but especially only for patients that have hypothalamic, yeah, and also people who have acute renal failure. But it doesn't mean that you cannot give it to them. You can give them, but you need to monitor closely. And also for people with ACE inhibitor usually have hypokalemia, but again, it doesn't always there. So you just need to monitor the patients. And right now, sometimes because we have more bradycardia if you have ACE inhibitor, and that's what makes the dry cough. And you can, sorry, you can also have angioedema. And also it's not for pregnant women, yeah. And same thing with ARD, yeah, but only less angioedema. And ARNI also have similar adverse effect, but the angioedema is very rare. So this is like angioedema. So diuretics, I think we all know that, right? Diuretics will make patients have produce urine a lot, and that's why it's gonna reduce the volume of the blood, and then that's gonna reduce the tension of blood pressure. Yeah, and that's also good because it will reduce preload, because we want to reduce preload in heart failure patient. And also because diuretics have some blood sodium reduction, and this is also good for our vascular resistance. Yeah, let's just go through it fast. So they are actually there are 5 types of diuretics, but what we use a lot is only loop diuretics, and then thiazides, and also potassium sparing diuretics, right? Maybe I don't need to explain this. But you all know this is what? What are they? Nephron, right? Nephron, glomerulus, and then also tuberous, proximal, and then epicenter, and then these are tubes, and then this is following that. Okay. Right, next. Okay, the adverse event. So, of course, because when we throw out a lot of potassium, sodium, and also a lot of liquid, then the most common side effect will be potassium depletion and hypovolemia, and also sodium depletion, yeah, and magnesium depletion, because we pee a lot. Yeah, that's what happens when you take diuretics. But some research have also found that diuretic can impair glucose tolerance. It means that people who on diuretic for a long time, they could develop hyperglycemia, right? So a little bit, we need to monitor the glucose tolerance of the patient who already in chronic diuretics, right? It also can increase serum lipid concentration, uric acid, and for the potassium sparing diuretic, it can cause hypokalemia instead of hypokalemia. I think you all get this from your classes. Okay, so beta receptor. Okay, there are lots of beta receptor, but for heart failure, we only use only three that can be used for people with heart failure. The first one is bisoprolol, yeah. Or if you don't have it, you can have carvedilol, and then if you don't have it, you can use metoprolol, but not propanolol, atenolol, and so on. Yeah, only these three. Okay, and then, well, beta receptor means that, beta receptor blocker means that we can save the ATP of the heart, the oxygen of the heart, because we make them work less. Yeah, the heart rate will be slower, the contractility will be not too strong, and that's why we're gonna reduce the oxygen demand, and we're gonna reduce also contractility and the oxygen demand. And this is why we still use beta blocker for heart failure patients. This is also not so common in Indonesian practice. The SGLT2 inhibitor, I don't know, in Thailand, they use it already? No? Yeah, this is dapagliflozin. Maybe dapagliflozin. Okay, so actually it's anti-diabetes treatment before. So it was introduced as anti-diabetic drugs. But then research shows that if you give this as SGLT2 inhibitor to people with heart failure, then their morbidity or their illness is better, and their mortality rate is lower. And that's why they're trying now the SGLT2 inhibitor to people with heart failure. So this is also not a common practice in Indonesia. But I think if it's popular in America or in Europe, it will come to Asia too.
One question.
Okay.
Because the last time I just saw in so I really listen when they said that is better and reduce the blood pressure. One question how they can reduce the from the data when we develop the
Well, actually, that, of course, that, depend on the structure and the effect of the drug itself, but I'm not really, know what is the difference in that term between the DAPA and INFA, right? Yeah, so for that question, probably I'm not the good, teacher for that. Yeah, because I'm not really into, the detail of, how the structure of the DAPA and the EMPA and how it affects different receptor.
But in your area, can you suggest when we use the data and should we use data change the diabetic patient should change from the MR to the data?
Well, this is still ongoing research, I think. I mean, I don't know if it's established or not, but I think it's not. So, well, some research would say that DAPA is better than EMPA, but I don't know because it's not in the guidelines yet, so we have to wait and see. But yeah, some research already said that probably DAPA is better than EMPA, but again, it's not my, oh, yeah.
But
Yeah.
because in 2023, in now they was very strong in the data.
Ah,
And they use combined from the data and metformin
oh, metformin, yeah.
on the diabetic patient.
Yeah.
That's the thing that I should think about, should we change a lot because when you change from the MR to the W, you should control the glucose level of the diabetic patient again.
Yeah,
Yes, and some of research I saw is the same, it's not change too much.
yeah, I know what you mean. Like I said, well, again, the research is ongoing, yeah, some research already in favor of DAPA, compared to EMPA. But it's still not in guidelines, right, that you have to switch from EMPA to DAPA. So,
Now in Vietnam have the recommended, right?
okay.
That's the thing.
Yeah.
I have to say about it.
All right, so in Vietnam now.
Yeah.
Oh, okay. I don't think in Indonesia already happened, so, yeah. Okay, again. Okay, so this is just the mechanism of action, so if you have SGLT2 inhibitor, it means that, you're going to have more glucose, to be excreted from your renal. Yeah, because glucose also bring water, I mean, so it means that you're gonna have less blood volume, right? Circulating to your heart again. Okay, so in that case, it's gonna be good for heart failure patients. Okay, so because we excrete much glucose through your urine, it means that you're gonna be prone to genital mycotic infection, urinary tract infections, because bacteria loves sugar, just like us, probably. Yeah, and then also you're gonna have increased urination and nausea and constipation. Okay, last but not least is cardiac glycoside, digoxin. This is not for every patient for heart failure. You have to see whether they need it or not, because this is it has very narrow therapeutic window, which means that we can get toxicity very quick. So if patients get digoxin, then we need to do TDM. Costly, yeah, therapeutic drug monitoring and, sample their blood and see whether the concentration is still within the, good range, right, not toxic range. Okay, and, oh yeah, I forgot to say that, digoxin can help, increasing the contractility of the heart, especially for those that have systolic heart failure, the one that cannot contract properly, right, not the one that have thickened ventricular wall, so it's different. And yeah, the adverse effect, just be careful because cardiac glycoside can have toxicity, it can cause fatal cardiac arrhythmias. Yeah, that's why I said patient usually need to have TDM monitoring. Yeah. And the conclusion. So if we see the pharmacology of drug used in the treatment of heart failure, generally it will target three things: the inhibition of neurohormonal activity, sympathetic stimulation, and also remodeling. I forgot to put that here. And then the recommendation now, including ACE inhibitors, ARB, RD, diuretics, beta blockers, aldosterone antagonists, GLP-2 inhibitors, and digoxin, only when required. Okay, back here, your patient, anybody want just have a short answer? What do you think you give this man? And if we guess, maybe. Oh, we just let it untreated. No. After all of that. Just mention anything. No wrong answer here.
Before he dies. Last. Just keep like say something before he dies.
Yeah, okay. All right. Can you tell me your name?
Hi guys, my name is Mariel from Thailand, my university. And for I don't know about like the other university, but in like skill university, we taught that there are like four main types of drugs that we use to cure like severe or severe, which is include the first one is like beta blocker. Yeah. And then RHA antagonist, sure. And then what else? Spironolactone or aldosterone antagonist.
Yeah.
And then the other one is like SGLT2 inhibitors.
Okay.
Yeah.
So what took you so long? They're all different answers, yeah, for that. That's four types of drugs that you need for heart failure. Your patient is well now, right? Because he already got treatment from Nora. Sorry, what's your name, please?
Noel.
Noel. Okay, from Noel, yeah. So give a question for Noel. Okay, so I think that's the end of my lecture. Thank you very much, and hopefully to see you again in Makassar. So these are Dr. Hill and the student, and also I think the committee are here. Yeah, some of them. Yeah. So we will welcome you, maybe from Mahido, Chiang Mai, and also Chungan. As a university, Makassar. Okay, so thank you very much.
No, and then that's what I do. John Cotton, right? I was 7. I just so on with you. you maybe already know from our student, the pink color is student Almarisah color in the CTU. And for the lecturer, we wear the blue colors. Normally we will wear on Monday and Thursday.
I never see you wearing.
I've never. I don't know why, but for me, when I go to another country, I always say it would be just I want to show up with the foreigner only. But in here, I know did you say the lecturer should wear, but in my case, I should not. Maybe because I work in the lab for day by day, so it's inconvenient for me to change. So now we don't have any question.
I just want to make sure that I understand it correctly. Yes. So ejection fraction for here is like equals stroke volume divided by a diastolic volume, right?
Yeah. And there's the volume is the volume just right before the systole, right? Yeah, so the filling volume, yeah. So yeah, that's correct. So stroke volume is the one that go out. So divided by whatever happens, whatever they are before.
Yeah, thank you.
Oh, still remember your lectures. Good.
So about that. Okay, it's not from me. And because I'm working on natural products chemistry, so for example, caffeine, why? It's been we know that this can make that effect, okay? But I know that it consists a lot of flavonoid. This means antioxidants. It is good for us. So what we're talking about.
Okay, all right. So caffeine can make your heart beat faster because it's do you know about adenosine? Yeah, adenosine is like your neurotransmitter that makes you relax, right? And caffeine is the antagonist of adenosine. It means that it will not make you relax. It makes your heart pumping faster and makes your heart also pumping forcefully, right? That's why some people when they drink coffee, they will have that, yeah, palpitation, something like that. I don't know about the antioxidant of the caffeine, and of course they do have it, coffee, I mean. But I think the immediate response is that it makes your heart beating faster. And because beating faster, of course, we have more energy, and more energy means easy exhausted heart. So it depends. If you like coffee that much like me, you can keep drinking it. Yeah, but of course you need to limit yourself. They say, I don't know if this is true research or not. No more than 3 cups of coffee every day. For wine, yeah. For wine is a little bit controversial, not controversial, like contradiction, yeah. Some people will say wine is good for your heart. Yeah, because of the antioxidants. But if it's too much, maybe because the alcohol content in it. So
I'm thinking about wine fruits.
oh, wine from yeah, I think it's good, yeah. Because I think in my class, we already talked, there is journal article about wine. You still remember why, can help, your heart function, like, because it has lots of antioxidant in it. So, yeah. Again. Yeah. Yeah. Okay, I think that's my answer. And
Yeah, I have one question to that. I think we have a lot of route we have a lot of route there, but we have a field drug. In this drug can use first treatment. And do we know the mechanism or we learn this by clinical trial?
so you're asking about the mechanism of beta blocker,
Yes.
for heart,
From heart failure.
for heart rate. Okay, okay, that's a good, question, because, well, instantly when we talking about beta blocker, we're gonna think about heart. Okay, beta blocker will decrease the heart rate and decrease the force of the heart. Don't we need that for heart failure patients? Is that, sometimes we think about that, right? Because heart failure means that it's already, the heart is already failed to pump. Why we need to give beta blocker again? So actually in this type of patient, in this condition, beta blocker is to reduce the rate of the heart to save, to preserve the ATP, and also to give a little bit of time of for the heart to relax. So because if you keep pumping, you don't have them to relax, and you need that for your heart to refill the ventricle. You need relaxation to refill the ventricle. So you need to reduce a little bit of your heart rate to enable the heart to refill, and also be safe to preserve energy. In that case, you will not have remodeling. It can also prevent remodeling. Okay.
No, I don't have one. Okay, but I'm maybe I'm not asking you, but I ask, I don't want to trust with everybody, so can you come to the slide? The 3 for the survey. Why is that country? Is so survey, try to find the reason why. Surveys and
Oh, yeah, the region.
yeah.
Yes. We are similar according to this line. Indonesia and Vietnam, mortality rates. So Eastern Asia, the Western Asia, it's a bit higher.
Okay, let's talk about it because our country is going in here, but I saw compared with another one, the yellow still low, compared with another area, right?
Well, relatively low, yeah. Thailand is better than us. In terms of mortality rate, yeah.
So actually, at the first count, I think because they, for example, Korea, maybe I think they have small food, more variety of food, so that's why they can control, they can reduce.
Yeah.
But when I look at Japan, I said, okay, my answer is wrong. Right? Japan, they also they really care about their health, but the numbers are very high.
But there are a lot of stress.
Uh,
It's a lot of stress.
lots of stress.
Attention.
And when I see this survey, I immediately thinking about the US, but the US is not included in here because I know if the weight is up more
Yeah, yeah.
and normally American is double about the weight.
Yeah.
But the survey is not so big.
But actually, Korea is not that bad. The Republic of Korea is down here. Like, it's not that bad compared to Japan.
Yes.
So.
People.
Maybe Korea is more happier life in Japan. So I want to ask all of you. So, for example, in Thailand, you're in the university. And say, for example, in faculty of pharmacy, we didn't have the structure. So it means we were, if we want our students to learn something, we send students outside. So how about your country? You have the store, and then how can they arrange? It means like, for example, in this time, 20%, in this time, another group, so they turn around. So how long? 1 week, 2 weeks for like in this internship. Yeah. So how about your system? You one group, 2 months.
Yeah.
In the
Do you mean that you have to the company or you mean
yes.
Not all students have gone.
Yeah, in Vietnam, the last year student, right? The 5th year student. So how about in Thailand?
Last year.
So and then how long it lasts?
No.
I think it's the different in the infrastructures. Because in that had the 6 year and in our country in 5 year only, and they have the 1 year for the practice. If you're working in the video conferences, you must come to the hospital part. Yes. And of course, for my university have the restaurant at the gates. Yeah. What no, for the lecturer, we will divide as the shift. And also have the same in the 2 hour university.
So it means if they want to move 6 years, so they have 1 year only practice.
That they don't have that this. That's right.
It means just study in the class. No, not go to the company. Not go to the hospital.
Let me just add. Okay, so we studied like 5 years university, and then 1 year in whatever you like, you're going to work. But before that, in like summer of your 4 year and 5 year, 5 years. You can like go and then it's compulsory. You have to go and like do like a training thing inside.
Okay. That's compulsory, right?
1.5. Yeah, it's compulsory for 4 years and 3 years inside.
How long do you do this? How long do you do this? 3 months or 1 month?
Maybe less than 2 months. Yes, 1.5.
So outside.
Yes, outside. นอกแต่ว่าเราก็มีในเครือของเราด้วย Like our university will like provide the list of the places that we can like go practice.
I still want to ask about the drugstore in your university. Are there any change for students to practice or just because of business?
Since we have a lot of drugstore, faculty there's
I think there's a board like some medicine like some drugs. The students can like get it for free. So we just like have to show the IDs for the credit, and then we get some of drugs with me. But they also like still more like normal.
and do you practice in
Yes.
It just I don't know that it can call like a practice, but we do have like a practice in like second year student. But it's very short period of time, like maybe 2 weeks. Oh, one day. We do absolutely nothing, which is like it's there. You know, our teachers, our professor will like provide, which is like awesome.
Yeah. So how about Philippine University? To that.
Oh, okay, computer science, okay. Oh, separated. Oh, pharmaceutical science and pharmacy are separated in two like. They're supposed to know.
No, I cannot collaborate with Philippine University, but I think that pharmaceutical science is the same. But it's not the same.
Clinical is different, like clinical and pharmaceutical science. But I think in our drugstore, there's they welcome the student from other university to like practice. I see a lot of students in drugstore that can work.
you are working as look at the pharmaceutical assistant.
Sorry.
When you practice in the drugstore, you working as look like the pharmacist assistant.
Yeah, I think something like that.
So you guys don't practice in drugstore, right?
No, yeah.
Outside. But you can have license to as pharmacist. The license. Okay.
when we have the opportunity to speak here, I want to ask a little bit in the pharmaceutical license. In your countries. How do you get the pharmaceutical license in your Indonesia or in Japan? Because in Thailand, you must be brother.
Everybody cannot.
Could you hear me? Because my major is the social economic and explanations. So I discussed about the license for the pharmacists in Vietnam. Because now in Vietnam, we will get is the standard for the pharmacists and also in the medical doctors. They think again to make have the provide the license by the test and 5 years to retest again. Yes. And I want to ask about the experience in your country that when do you get the license and how you really provide the license certificate? Yes, it's certificate.
Maybe go first.
Yeah.
Okay. So. So in Indonesia, for the license, we have to go through like two national tests. One is CBT test, that means that you use computerized test, and then second one is OSCE. So clinical test, yeah, clinical skill test. So you have to pass that first, and then you're gonna get licensed. And then after 5 years, I think we need to be, yeah, retest again. So probably the same in Vietnam. No?
So in case you cannot ask again about something like this one, what area you can work? Okay.
Yeah.
Actually, kind of the certificate, there are two types. One for the clinician using that means one for pharmacists that can still in the working in pharmacy or in hospital or in the industry. They can use the like portfolio base like that. That means no need to that's kind of the examination like that. But for the other one that not work in kind of the pharmacy, but you still want to maintain the license as a pharmacist, they can be doing through the hospital as well. It's like that.
And before you so practice in the hospital.
I think in the the last year.
But you can get the lesson after you graduate in the 6th year or before. And yes.
Took maybe 5 years, but every year you have to get the point. Yeah.
I achieved the study in and how many points you must get?
100
What 100?
per year.
Could you equivalent the how many costs?
It's depending on the cost that is happening or yeah, you choose to go. It's like a friend or living something. Yeah, and the one is not the same.
Thank you very much.
So how about visiting you? You want to say
Yeah.
or something, huh? You want to say something or you want to improve something in our
I think that I'm say all of him does I can say.
because I think I asked this question also good for you. If in the future you want to go abroad or you want to work with foreigner, you should know who they are and who about their knowledge, their anything. It's so any question more? I saw some of you read Scott so why? So it means you got to know are you okay? How are you? Okay. And so I think we will finish today. And see you tomorrow. I will schedule my session to all of you. One thing I forgot Monday. So please give me Monday of the tour until tomorrow because I need to book, I need to pay for the comedy. Okay, tomorrow is it's okay, it's tomorrow and actually we will
So you're right away after.
okay. I prefer Việt Nam đồng more than US dollar, but if you get US dollar, so you can go to the bank. We will have an ATM here if you want to take our money. And today I think so early to tell what you prefer yesterday. So the last day, it's been the day after tomorrow. I will tell you what to do in Nha City. So to support you have good experience in Nha City now. So early, if I say maybe you cannot remember. So just the day here. Okay, we finished here. Before we finish school, we will take the photo together. And then we will invite you for lunch at 11. So committee lunch at 11 right? For lunch today at 11. So how can you arrange with them? Just like that. So where you, because now only no more than 11 people, what will you do? No, because we already have an appointment at, sorry, we already booked at 11 or 11:15. So what will you do now? Take a round or
Yourself.
yeah, okay.